Dr. Soumya, you can start, please.
Okay. Good evening, all. I'm Dr. Soumya Nagarajan, and I welcome you to the second episode of ISA's Clinical Excellence Masterclass. Today, we would be having case-based discussion on allergen immunotherapy, and the moderator for this session is Dr. Gayatri Pandit. Dr. Gayatri is a senior ENT specialist and an allergy specialist practicing in Bangalore. In Samarth ENT Allergy Clinic and in Manipal hospitals. And she has various publications to her name, and she's a well-known authority in the aspect of allergen immunotherapy in our country. And thank you, Dr. Gayatri, for agreeing to be moderator for this interesting session on case-based discussion on allergen immunotherapy. Thank you. And it's my also pleasure to invite and introduce Dr. V. Raghuram Reddy, sir, from Guntur, Andhra Pradesh. Sir is a senior pediatrician and an allergy specialist. And sir has been he has done his allergy training from ASC and subsequently from FAP. Sir has served as Secretary of IAP Guntur branch until 2014, a very long-standing tenure, I think. And sir is academically very active and presently serves as the President of IAP AP State. Sir is a very avid clinician, and I think we have much more to learn from his clinical experience based on this case-based discussion on allergen immunotherapy. Sir, over to you, sir. Thank you.
Thank you, ma'am. Thank you.
You can, yeah. So you can start there. You can start presenting, and we will have a discussion with your case as and then when you are presenting. Okay.
My pronouns to my teachers. So the first case is 34 years male, female, complaining of sneezing and running nose of 4 years duration. Cough was occasional, more at night. It's also of 4 years duration, but it never troubled her. Used multiple antibiotics, antihistamines, and montelukast. She also tried homeopathy for 1 year. The nasal symptoms are sneezing early in the morning, associated with nasal obstruction, watery nasal discharge, and she has nasal itching. And I observed the salute sign in my clinic also while examining her. The symptoms are perennial, more during winter. Cough is occasional, dry cough, more at night, but never give a trouble to her life, more frequent in the winter. There are no eye symptoms, either redness or itching, and there is no history suggestive of atopic dermatitis in her childhood. She lives in a village 5 kilometers away from Guntur city, living in an independent house, well ventilated, no pets at house, no molds, no tobacco smoking at house. The second born to non-consanguineously married parents, no family history of any allergic disease, and she has 2 children, both are healthy. This type of symptoms are not being seen in the kids. Her physical examination is normal except for anemia. Throat was normal. She has DNS to the left and bilateral inferior turbinate hypertrophy. Eyes are normal, no clubbing. She has allergic shyness. The FOT conducted shows there is significant bronchodilator reversibility. The R5 minus R19 shows 62 per change, and X5 shows 33, and AX shows 48. So it indicates a good bronchodilator reversibility. The anterior rhinoscopy.
Can you just go back to your FOD? Yeah, so the previous, this one. Okay. So how was her R5 and R19 in the baseline?
This is the first one, madam. She's our first visit for.
So the pre, what I meant is pre. I just wanted to see. Well,
Pre R5 is 2.8, madam.
okay. So the baseline still
It is
appears,
normal, madam.
yeah, the
Normal.
baseline appears good, but except that we are seeing a good reversibility in
Yes.
AX
Yes, madam.
in your R5 minus R19.
Yes.
If
AX is
we look
more.
for reversibility in R5, AX and FRES are the values that we usually look for the
Yes.
reversibility.
Yes. Except R5, AX and pre-res are more in the pre also, madam.
Yes.
Anti-rhinoscopy shows bilateral hypertrophied inferior turbinate, and there is grade 2 adenoid hypertrophy, and there is a gross deviation of the septum.
Yeah. Sir, would we do nasal endoscopy for all patients with allergic rhinitis, or was there any specific indicator for you to, do a nasal endoscopy for her?
No, I don't do it for every patient, madam.
Yeah.
If it is a chronic and there is an obstruction causing more symptoms, obstructive symptoms are more, we'll go for endoscopy, madam.
And as for your surprise that you have seen that there is in the nasopharynx, there is grade 2
Yes, madam.
adenoids are also
Yes.
there. For her age, we wouldn't expect otherwise adenoids to be there, isn't it?
Yes, yes, madam. Yes.
But it is not surprising that many a times that when we do endoscopy for some other purpose, then we end up seeing that there will be sometimes even remnant adenoids between grade 1 to grade 2, even in adult population, it is quite common to see. So sometimes that may be the one which is adding on to added obstruction.
Yes.
So if somebody, a mere case of allergic rhinitis, for us, ENTs, it is different because for us, it becomes like a part of routine examination and we might put the 2 pediatric scope in many of our patients just as just one pass in and out. But if non-ENT practitioner is treating allergic rhinitis, and the indication for nasal endoscopy specifically would be they start the treatment for patient with a nasal spray or whatever the treatment that you have planned for. Patient comes back and tells that my nasal obstruction is still not better and my probably the sneezing, all those things are better, then definitely that would demand nasal endoscopy. And especially, did your patient also had any decreased smell sensation or loss of
No,
smell?
madam. No, madam. Even she did not have snoring also.
Okay. Okay, because that's another indication that in AR patient that I would want endoscopy to be done.
Yes. And then I did skin prick test. It showed DP 8 into 10 millimeters with pseudopodia, DF with 7 into 5 millimeters, and blomia tropicalis is 6 millimeters, cockroach 6 into 13. So she is sensitized to DP, DF, blomia, and cockroach. And controls were normal.
Controls good.
Yes, saline was negative and histamine was 6 into 9 millimeters.
Okay. So were you expecting this reaction or were you not expecting these reactions?
I don't get manner.
When you were doing the skin prick allergy test, depending
Yes,
on
yes.
the initial history that you had, were you expecting these reactions to come? Were you expecting a dust mite reactions to come, or this was a surprise for you?
No, I was expecting, madam, because the symptoms are perennial, indoor, and more in the night time, early morning sneezings, are all clinically correlating with the dust mite allergy. So these are expected only. Even if the cockroach also expected, madam, because it's an indoor allergen.
True. Yeah. Next slide.
So then I went for second history. Symptoms are perennial, more in winter, and symptoms are more in the morning and indoor, and they are progressive. Symptoms are progressive because he is trying many modalities of treatment for all these 4 years, and all the symptoms are correlating with the house dust mite allergy.
Mm, mm. So symptoms are more in winter time. Uh, so do you have any justification that why dust mites are perennial and we do expect the symptoms to be there all the time? So why is that the symptoms are more in winter?
It's because of the high humidity. The population is more during winter month.
Mm. So winter, your extreme winter can have the lesser humidity also, but there are some other factors also maybe that, the kind of a clothing during the winter time
Yes,
that
yes, yes.
when you would, take out all your furry clothings or even the blanket you might shift over to a little more a furrier one. We might shed more skin during the winter time, giving them more food also.
Yes.
So these are the factors where it might add on to her winter symptoms. Yeah, so your history is matching well. So whatever the second history that where we try to see whether our sensitization is causing her symptoms. So whether from to understand from sensitization to allergy, yes, your patient does seem to have suffering from house dust mite allergy. So what next? What was your plan?
So I advised her about the allergen avoidance and then start with pharmacotherapy. And I discussed immunotherapy with her. Once she gives consent, we will proceed with immunotherapy.
Okay. So this patient, was she ever on pharmacotherapy, proper pharmacotherapy, or was she only
Never,
taking
madam. She was
histamine
never
also?
in proper pharmacotherapy. She used only for very short intervals. Even she used international corticosteroids also, but it was only 15 days, 1 month like that.
Yeah, yeah.
But it was never a continuous therapy for 3 months.
Mm,
And she never had the bronchodilators because she was not having the much symptoms.
mm,
She was more on antihistaminics and montelukast.
mm,
And she almost lost 1 year with homeopathy treatment.
mm,
So she was never given a full pharmacotherapy
mm.
trial.
Yeah. So this is how our typical cases are most of the time that
Yes.
they have they express about inadequate control or they also mention about not having a adequate relief, but they wouldn't have taken the pharmacotherapy also adequately and like the way that it has to be given. So before we even think about immunotherapy or something, so I would just want to also hear from you what is the kind of pharmacotherapy and what is the duration of a pharmacotherapy and how you would plan follow for this patient?
So these are the advices I have given to her to wash the bed sheets and pillow covers uh, twice a week in hot water more than 70 degrees centigrade. Vacuum cleaning the bed, pillows and sofas. Avoid carpets at house, and to avoid brooming and use only wet mopping. And if possible, use mite proof covers for pillows and mattresses. The pharmacotherapy I advised her is international steroids, fluticasone furoate, and for her symptoms of lung, I advise her low dose ICS with formoterol, this is MART therapy, and oral fexofenadine for 1 month, and international corticosteroids for 3 months.
Okay, so how would you follow up this patient? Now you have given the one for the 3 months time, another for 1 month time. So how would you want to follow up and when do you want to really decide that yes, I would want to initiate immunotherapy for this patient?
I will see her after 2 weeks, madam, to see the response, both response towards asthma and allergic rhinitis. And I will take the chance to discuss about immunotherapy and prepare her for immunotherapy. After a month or so, we will initiate along with pharmacotherapy, immunotherapy also, madam.
Mm.
Because since the disease is progressing and she is also young, I don't want to lose much time to wait for immunotherapy, madam.
So what would be your, the counseling points for the, people who are wanting to learn about the immunotherapy? What words do you use in your counseling for the patient to convince them for immunotherapy once you feel that this is a right candidate?
I tell her about the disease and its progression, because if the treatment is not taken, disease progresses and she will land in multiple problems, so rhinosinusitis related problems. And I will give her option of treatment, pharmacotherapy, and the limitations of pharmacotherapy. Because this pharmacotherapy, we cannot use it continuously for the rest of our life. It has its own side effects.
And most it
And
is not a disease modifier. It will give a
yes, it
good,
is
but
not disease
it's a
modifier.
symptom reliever.
Yes, whole symptom reliever. And I tell her that's another therapy called immunotherapy, which has a disease control and regression. It causes disease modification, gives a long-term relief from the symptoms. And I tell her about the course of the treatment and to use pharmacotherapy in the initially along with the immunotherapy and during exaggerations of the disease. And the long-term benefits of immunotherapy also I will explain, because after even using it for 3 to 5 years, the clinical benefit will be seen for 8 to 10 years. I will try to convince her about on these points and start the immunotherapy.
Yeah, true. Very much true. You can definitely use the same line of, in your lines of counseling. Patients often ask, is there, will my allergy be cured when, when I take immunotherapy? So is there any wise way that you tell them?
I use the word it definitely improves your quality of life and quality of sleep, and definitely the symptoms are more and need for pharmacotherapy will be very, very less.
True, true. So I also tell them that, in a scale of 0 to 10, if you're suffering around 8 or 9, so probably with immunotherapy, we will be able to bring it to 1 or 2. So you are not promising 0 straight away, but there are patients who will be at a 0 also, so that, you are giving them a good promise, but you are also not, straight away promising kind of a, cure in your allergen immunotherapy.
Yes.
So whenever we are discussing about immunotherapy, the 3 things we always discuss, isn't it? The 3 aspects is something that we are going to discuss on. One is that, is he a candidate for immunotherapy? That is the proper candidate selection. Second one is a proper allergen selection. And third one is a quality of the allergen. So of course, the quality of the allergen, as a doctor, we don't have a hand to modify in that. That depends on the availability of the allergens that we have an access to. But if we consider the first 2 factors, so so would your case justify? And you can just tell the points for your justification.
Yes, madam. My patient is suffering with the allergic rhinitis symptoms for the last 4 years. She is young. She is a good candidate for the immunotherapy because the disease is not progressed much. Second is my skin prick test showed good result, and it is correlating clinically well with the symptoms. With these both things, I can say she is a good candidate for immunotherapy, and we'll select good immunotherapy medicine also, madam.
My one small comment here will be, definitely allergen wise, dust mite is a good allergen to treat. We know that we have a good level of evidence for house dust mite immunotherapy correlating well. So definitely allergen wise, a good candidate for allergen immunotherapy. At this point, the candidate wise, yes, the candidate has shown a progression. A candidate has both allergic rhinitis and probably some amount of the lower airway obstructive reversible disease also. But how well motivated patient is also for the 3-year therapy. Look, if this patient has never taken a pharmacotherapy, I would take a little longer time to understand her compliance to medication. Whether she would stick on to nasal spray, whether she understands that, immunotherapy is not a total replacement for pharmacotherapy. So I'll take a little time there. And also see, there are a set of patients who do very well once we initiate pharmacotherapy, and they do just well on avoidance measures also. So I would stop pharmacotherapy or reduce pharmacotherapy after some time. And at that point, if her symptom starts recurring back, then she will only come and demand. I would definitely counsel her about immunotherapy, but not push too much on immunotherapy in the beginning. But once we reduce the medication, if her symptoms start showing up again, then I would definitely press more on immunotherapy that time. And then the demand comes from the patient. And then that makes it more, adherent to the treatment also. So when patient demands the treatment, immunotherapy compliance also improves. Otherwise, definitely a good candidate for immunotherapy. Yes, sir. Did you initiate or what was your this thing on this case?
I also tell her that the clinical response can be seen only after 1 year, and don't be in a hurry to search for the clinical results. So treatment has to be continued after 1 year, and average 3.5 to 5 years. So if there is no response after 1 year, we will re-evaluate, and probably we may go into component resolved diagnostic test to see whether there is anything that can be done at that time, at that point of time.
Sure. So what was your plan? Did you started immunotherapy for this patient?
No, I just advised her, and
Mm.
she has to come back after 14, 15 days. So this is only my prescription in, I have not even started on her. I have started her on only with pharmacotherapy.
Okay, okay, fine. So what were the option? Like I know that Sensibin is one option, that one good option that you have. So
Yes.
the option would also be
We can also go for subcutaneous immunotherapy or sublingual immunotherapy to oral liquid also. But I am not practicing subcutaneous immunotherapy. And for the last uh, experience with the Sensimin is it's giving better results than the oral liquids.
sublingual drops.
Yes, madam, sublingual
So
drops.
I would also give option of both to them, the whatever the available modality of the treatment,
Yes,
like
yes,
from
yes.
the sublingual drops to the sublingual tablet to the subcutaneous injection, and explain them the advantage, disadvantage of each modality, and then I keep it open to patient to choose what is more doable for them. So that is how that I do it with the immunotherapy.
Yes, madam, because the cost implications are also there.
Cost implication, frequent visits, they are traveling, the way that they would, whether they're going to be there in one city or they're frequent travelers. So there are many other things to be considered while taking a decision, their near future plans. So all these things will need to be taken
Yes,
into consideration when we decide on what mode of immunotherapy also.
yes, madam.
Yes, sir. We'll move on.
So next case is a 31 years old bank employee presented with sneezings, nasal discharge, nasal block, and nasal itching of 8 years duration. He also used cetirizine initially, now on cetirizine with montelukast on SOS basis. He used slit medicine with HDM tablets from Bangalore Allergy Center at Bangalore for 1 year when he was working there in Bangalore. So the nose symptoms are sneezing again more in the morning, and nasal obstruction and nasal discharge is watery. He has nasal itching. Symptoms are more during winter. Symptoms are more when he visits his village nearby 15 kilometers from Guntur.
Can we just go back to previous slide? Just wanted to so symptoms are more during winter and more indoor, outdoor.
Indoor, madam. Indoor, and the symptoms are more when he visits the village, madam. He goes to village on weekends for the. He is agriculture family, madam. He goes to his fields.
Okay, what's his occupation?
He is a bank employee.
Bank employee. Okay. Okay.
But family does agriculture.
Okay.
And cough is occasional dry cough. And there were no eye symptoms. There was no history sized to of atopic dermatitis. And he is living in Guntur city and visits his village frequently. He lives in an independent house, well ventilated, no pets at house, no molds or no tobacco smoking. And he was born in the village, and school education was at the village and college at Guntur. developed the symptoms during his stay at Hyderabad for bank exam coaching at 22 years of age. Lived in Bangalore from 2017 to 2020. So at that time, he started his treatment, and family is agriculture family, and he frequently goes to village and goes to field also. Father is having asthma and he has two children, both are healthy. They are not having any symptoms. Physical examination unremarkable, and he has nasal findings. Bilateral nasal cavities are narrow and there is inferior terminate hypertrophy. This is his skin prick test report. It shows cockroach 4 mm and cynodon 17 into 12 millimeters with pseudopodia and erythema. Timothy grass 12 into 12 millimeters with pseudopodia and erythema. GM is 22 into 11 millimeters with pseudopodia and erythema. Chenopodium 13 into 8 millimeters with pseudopodia and erythema. Riccinus communis 12 into 9 millimeters. Holoptelia 6 millimeters. Prosophis julipera 14 into 9 millimeters with pseudopodia and erythema. Cassia siamia 6 millimeters. So this I did it long back in 2022. So Holoptelia trees are not seen in our area. And Riccinus communis is also very less in our area. But we have Cynodon, Giamis, Chenopodium, and Prosophis juliflora and juliflora more in our area. So if we go through the pollen calendar, Cynodon is a severe allergen. It pollinates between March and May and August and December. And GMS is also a severe allergen, pollinates between September and October. Chenopodium is a moderate allergen and pollinates between March and April. Riccinus communis is a mild allergen, pollinates between November and December. Prosophis julipera is a moderate allergen, pollinates between March and May and September and December. So keeping the pollination time in view and the severity of allergens, I went back to the second history. Those symptoms are more in the winter and more in the morning, and symptoms are more when he visits the village. And he also identified GMEs and Prosophis julipera at his village. GMEs is his fields. Prosophis julipera is seen in vacant lands, and the symptoms are progressive. So I prefer to give
What about
Cynodon.
dust mite? Dust mite was not positive at all, is it? He was on dust
Yes,
mite
not
therapy.
positive, madam. Dust mite was not positive this time. It
So
was negative.
did you had his earlier SPT report?
No,
He had
madam.
it done in Bangalore.
No, he has not shown, but he has shown the prescription of tablets.
Okay. And he had taken for 1 year that
1
time.
year. He has taken for 1 year.
Was he partially better with the immunotherapy or was he not at all
No,
better?
madam, he did not get any response, and by the time he had transferred to Guntur, so he came back. And after coming back to Guntur, he visited me after a year.
Yeah. So if somebody does not respond to immunotherapy at the end of 1 year, so what all are the things to recheck?
So we have to check whether the actually the test report was accurate or not, and whether the symptoms are correlated well with the report or not. And the immunotherapy, the quality of immunotherapy was given as right one or not. And the compliance, when the patient has taken it regularly, these things we have to assess, madam.
Correct. And also probably also on the dosage. So
Yes.
when we are giving a sublingual immunotherapy, we don't have definite dose response curve, isn't it? But what we know is high dose sublingual immunotherapy works. So what we are giving might have been a very low dose immunotherapy, and that's why patient wouldn't have responded. And polysensitization.
Yes.
The thing that I see in your patient probably is that the patient is getting neosensitized over a period of a time. So that is why patient is not having adequate control. And one other thing, as you mentioned with your previous cases, very rare possibility though, that somebody who was positive on SPT and then was on component was positive only on a DERP23 and not responding to immunotherapy is a little rare scenario because they wouldn't have come positive even on SPT for that matter. So,
Yes,
isn't
ma'am.
it?
Yes.
So these are the factors that you will have to recheck on to. And one very important thing that when somebody comes and tells me that I'm not improving, I ask them, what is not improving? Okay. So for you, you must have achieved patient's runny nose is better, sneezing is better, the medication score has gone better. But for patient, the nasal block was the more bothering symptoms even before, and that remained like that. Okay, so then patient will come and tell you that, no, I have not improved. So it would be a good idea to ask what has improved, what has not improved. So I usually put my question in that way to understand that where I need to address more. So if patient tells that my sneezing, runny nose, itching itself has not become better every day, only if I take one anti-allergy tablet, only my sneezing will be better, then I know that I have to work more in this allergy line itself. So if patient tells that, no, the other things are better, much better from before, but my blockage seems to be more or worse, then I will work more towards some anatomical,
Yes.
like whether concha bullosa is there or some other sinus inflammation is also adding up or a postnasal drip which the patient is bothered about. Yeah. So yes, sir. What was your plan for this?
So I had started immunotherapy with the Synodon 30%, GMS 40, and Pusafase Julipata. Since these were antigens were tested with Alcure Pharma, I started this treatment.
Okay, so you go back to your this one that which you have put it.
Yes, ma'am.
Yes,
There are two weed pollens, Synodon and GMS. Uh, sorry.
correct. So the grass,
Yes, yes.
the pollens, the grass pollens.
Grass pollens. I have
Yeah.
selected these two because there was a good relation with the GMS.
Mm.
And Cynodon is very
Do
prevalent
they
in this
grow?
area.
Do they grow, Zia, in
Yes, ma'am. They have maize fields.
maize fields itself?
Hmm.
Okay. So I agree to your
Yes, ma'am. Otherwise, I would have chosen Chenopodium, ma'am.
certain extent, but I also differ it in one small way. Okay. So I'm not pretty sure. I haven't roamed around in Guntur much, but Ricinus is also one of the very dominant. You have put it as a mild sensitizer. But I would not really consider Ricinus as a mild sensitizer. Ricinus is definitely something there where I would consider it as a moderate or a moderate to severe sensitizer.
Hmm.
Between Cynodon and the Ziamis, both are from Poaceae family.
Yes, ma'am. Yes.
And they do have good cross reactivity. Okay, though that one is a wild grass and the other one is a cultivated grass.
Okay.
And patient is having symptoms every time patient visits a village and visits his field. And if it is a field, if it is a Ziames field, it's going to be a huge exposure, isn't it? Because the
Yes,
whole
yes,
field
ma'am.
will be with Zia.
Yes,
So
ma'am.
I would definitely keep Ziames for in immunotherapy. And then prosop is definitely again yes, because prosop is grows in a very dry, semi-arid areas, arid areas. Again, very potent allergen in your belt. In your,
Yes.
I think, Andhra belt, it is one of the allergen to be, the pollen allergen to be considered. So I would definitely consider that. But maybe instead of adding another Cynodon, I would have chosen the Ricinus. I don't know, but truly
Yes.
speaking, I don't know I haven't
I think
I
he
have
got.
gone around that area, but not specifically in and around Guntur. But I would, I'm still favorite of a Ricinus and I might still would want to think on possibilities of exposure because that is again a winter pollen.
Yes.
Ricinus is also winter pollen. So, and your patient's symptoms are also more in winter. So, I would probably give a little respect to Ricinus too. That would be only difference in my prescription.
Yes. I thought he got exposed it in Bangalore, madam. So
Mm.
because business community is not a prevalent in our area.
Because that also kind of grows in a dry
Yes, ma'am. Yes.
lands also. So, yeah. So Chenopodium and again one unusual thing which I'm seeing here
Yes.
is between your Chenopodium and Amaranthus. So they again have some amount of a cross reactivity.
That's
And
right.
I see that so much of a reaction to Chenopodium and Amaranthus hasn't given much reactions at all. So what do we do when we have such little unrelated reactions in SPT? I would expect some amount of a reaction to Amaranthus, like, at least 4 millimeter or a 5 millimeter reaction. But Amaranthus has come totally zero.
No, all these antigens are used from Clinimed.
Yeah.
Uh,
So what I would do when I expect some allergen to come positive, like, when I test for Parthename is usually positive, Xanthium also comes positive many a times. Maybe the reactions are a little lesser. So the cross-reactive, like the way that, see, you have got
yes,
a Cynodon, Timothy, Ziamase, everything positive, isn't
yes,
it?
yes,
Now, if
yes,
you have got Ziamase 22/11 and Cynodon totally zero, then it would be like you will have to doubt, isn't it?
yes,
So is
yes,
there
yes.
something wrong in the test that I did? Or was there any, some contamination when I did a Ziamase pricking itself? So, if the decision of immunotherapy had to be taken on some particular allergen, and then you need to be very sure that whether between these two allergens which to choose, the better idea will be again to retest them. Okay, so retest them with only that 2-3 more allergens that you would want to take a decision on to use a different lancet and do it. You can choose another day and do it. You don't need to do it on the same day because we are taking a decision for our patients for 3 years. So
Yes.
we also better be sure when we do that. So in such doubtful cases, or when I doubt on that why this came so much positive and why the other is totally negative. So I would just want to be very sure by myself, yes, that is totally negative. I would do it again second time on another day, especially if I have to take a call on allergen immunotherapy. Okay.
Sure.
Oh, yeah. So Chenopodium, again, we don't see much down in south. It's mostly north, more in the Batua is more in northern parts of India. We see more of Amaranthus here
Yes.
down. So that's why I was just thinking on that. Okay, okay, sir. So otherwise, my one this thing would still be, my
Yes.
one suspect would still be on Ricinus, and I would, work a little more towards that. Otherwise, I would agree with your prescription. So now, a right candidate for immunotherapy, let us discuss on whether it's a right candidate, right allergen.
So, yes, madam, he's the right candidate because he's suffering from last 8 years, and skin prick test also picked up the major allergens, and this disease is also progressing. And he used pharmacotherapy well during his stay in Bangalore,
Correct.
but he did not get any
Yeah.
response.
So here, candidate-wise, I would agree. Yes, definitely a good candidate for
Yes,
immunotherapy.
yes.
Allergen-wise,
Allergen wise, because I have been using for him, response is moderate, madam, not good response for the last 2.5, 3 years.
yeah.
So
So why
probably
do you think that he may be moderately be responding?
maybe my immunotherapy selection is what you said is I missed it, madam. Listeners, I
Yeah, that's
missed it.
okay. That may be one small
Mm,
factor. Yes, that I would still think on that one factor to be there.
mm.
The other thing is also
And
look at his sensitization pattern. Like, look at his so many things being positive,
yes,
isn't it?
yes, madam.
Like he has a Amaranthaceae family positive. He has that Mimosaceae family positive, Fabaceae family positive. He has the Poaceae family, the grassful, positive. So he seems like a little polysensitized, and whether this polysensitization, polyallergy really matching well is little difficult to delineate when it really comes to pollen. So your earlier patient by allergen wise was the best candidate
Yes, yes, madam.
because it was a clear cut history, dust mite and the cockroach, that, they do have a, cross reactivity to some certain extent, very straightforward. But this doesn't seem like that straightforward case. Yes, but you would
Yes,
definitely offer immunotherapy Because just on pharmacotherapy, patient may not have adequate control and patient has tried it, but response to your immunotherapy may not be as great as your first patient. Okay.
I have a plan to redo the skin test now, madam, to know the neosensitization again, any other neosensitization, and I will check back Artemis Amaranthus also this time.
If patient asks by themselves that, I want to understand if I'm responding to immunotherapy, and would you do please do a repeat skin prick allergy test for me. So would you do it?
No, madam. No, madam. Because it doesn't exactly correlate with the progression or improvement with the treatment, madam.
Yeah, so skin prick test
Still
is
there may be
a technological
sensitization.
test. So it can still be positive even when
Yes.
patient is responding. So if at all, if you're planning, explain about these things to your patient and then do it. Because patient sees that his DMAs has not come down, and then he will start questioning you whether my immunotherapy is working. So yes, though it is said that the size of your wheal and flare can become little lesser over a period of time. So there is an immunological lag in the skin prick positivity. So person can symptomatically become better, but allergy test can still be positive. Okay. Yes, sir.
So I explained him about the allergen avoidance measures for the pollen to keep the windows closed during pollen season and plan indoor activity more on high pollen days and add medication during allergy season. So luckily, my patient changed his cultivation. They're not growing now maize, madam, because
But
they have alternate
if the other
crops.
fields are growing the maize on this thing, that would still give him exposure, because usually I think
Yes, yes,
it's a pattern that one zone, the best crop that is grown in that area, the others will still be growing.
yes, yes. The pharmacotherapy was started with the fluticasone furoate nasal spray and oral fexofenadine, and immunotherapy, as
Yeah,
you
I
said,
think we
madam.
discussed on
Yeah.
this. You can just yeah, you can move on, sir.
So third case is 12-year child, not for sneezings and cough from 3 years of age. He also used antihistamines and antibiotics. The first time I have evaluated him in 2022 and started him on pharmacotherapy with international corticosteroids and ICS and SOS SABA. Started SLIT in November 2022 and continued for 2 years. And he stopped SLIT in 2024. The reason I was told is the results are moderate and child is free from the symptoms, hence they have stopped it. With both the parents are doctors. Now from 2025, the child is having increasing symptoms and requiring daily oral antihistaminics and bronchodilators. He also underwent adenoidectomy at 6 years of age. The nasal symptoms are predominant in the morning with nasal sneezing, abstraction and discharge and itching. Symptoms are perennial and there is a sleep disturbance. Symptoms are less during the periods of INS and usage of SLIT usage. There is a poor quality of sleep. He has a daytime drowsiness, but school performance is good. The cough is dry, more at night, wakes up 2 to 3 times in the night, 5 to 6 times in a week. Perennial, more frequent from October 2025. No shortness of breath. Symptoms are relieved with oral salbutamol syrup. No previous hospitalizations. Eye symptoms are nil. No redness or itching. There was no history suggestive of atopic dermatitis. He is living in Guntur city along with grandparents. Visits parents on weekends at Narsarapeta. It's also a district headquarters. Living in an apartment, well ventilated, no pets at house, no molds, or no tobacco smoking at house. He is the first born to non-consanguineously married parents. Father has bronchial asthma. Younger sibling is healthy. Physical examination is unremarkable. And the nasal findings are he has DNS to left and bilateral inferior terminate hypertrophy. He also has allergic shyness. His I did FOT. So FOT findings are the R5 is the same as the cutoff, but there is a 31% change in post bronchodilator. R5 minus 19 also has 81% change in the post bronchodilator. X5 48 and area of AX 50% and free X is 12%. So there is a good bronchodilator response, and reversibility in this patient. The anterior endoscopy shows allergic mucosal changes and DNS.
Okay.
And these are the skin prick test results done in 2022 and 2026, both.
So let's just see 1 minute.
Yes.
Let's just see that. Oh, okay. So you have summarized here.
Yes. In 2022, the DP was 18 to 6 millimeters, DF was 3 millimeters, and bromia 4 millimeters. In 2026, DP was 12 into 22 millimeters, and DF 16 into 10 millimeters, and bromia 6 millimeters. So these two are clinimed antigens. Cockroach is 9 into 12. We did all cure also with all cure antigen also. DP showed 6 into 9 millimeters, DF showed 7 into 15 millimeters, and Blomia 16 to 14 millimeters in duration.
So
he's
in 2022, he had started with immunotherapy, had taken for some time.
yes, ma'am.
Then the symptoms were better and patient left immunotherapy.
Yes, ma'am.
So, and now again the symptoms are there and now you have done the, is
Yes.
it what? Okay.
Yes, ma'am.
Okay. So what you clearly see here?
I see there is a neosensitization with cockroach. It was not there in that earlier. And the reaction also, sensitization reaction is also
Yeah.
grossly increased.
Correct. So even the sensitization, the level seems more.
Yes, yes.
So though we don't correlate that, the bigger reactions means the bigger symptoms. No, we don't correlate, but you can also ask like, how itchy all those things were and you have mentioned about pseudopodia in your reaction. So that
Yes.
definitely indicates, the presence of, it indirectly tells us about the severity. And last time, I think only DP was sensitized, and now you do see DF, DP, and to a certain extent, even Blomia being
Also.
sensitized. So, what's your plan? Definitely, I'm pretty sure that this patient, you
Yes.
said that, requiring antihistamines quite often, earlier had shown a response to immunotherapy,
Yes.
has a family histories of allergy, father being asthmatic is what you mentioned. No,
Yes,
sir?
ma'am. Yes, ma'am.
Yeah. So candidate wise, good candidate.
He's a good candidate for immunotherapy, madam.
Showing progression in your even in your
Yes.
sensitization pattern.
Yes.
Also has a lower airway involvement now, and you need to prevent that. So allergen wise, also good correlation and a good candidate for immunotherapy.
Yes.
But what is the challenge in this patient now?
No, because he has not completed his duration of therapy.
Yeah.
So now I'm in a dilemma when we restart the therapy, whether my immunotherapy is going to be a success or not.
Okay.
And
So what is
to
both the edges are difficult. So somebody who doesn't find a response leaves the treatment. Somebody who finds a good response and stops immunotherapy. So how do we keep our patients motivated? Once who is shows response.
yes,
What is
usually in my practice I call them once in a month, madam.
Oh, okay.
Once in a month I call them and speak over phone. And if they are within the city, I give them medicine only for 1 month. So they have to come back and give the response, and then they can take on the one more bottle for the second month. If they're away, I give 3 months medicine, but I give a call after 1 month That's how I maintain a good rapport with them, and they also continue, madam.
Okay. So we do what's usually the compliance rate of allergen immunotherapy when it comes to sublingual immunotherapy? So because
Despite
we are
all these things,
focused on
yes, madam.
sublingual immunotherapy today, so that's why I'm asking. So how much
Uh,
compliance do you think?
Compliance is around 60 to 70%, madam. Because more patient expectation may be different, madam. Because if they don't get the response immediately, some are getting dropped.
Yeah.
So that is the
I
majority
think
of the cases.
70% is too high. Okay,
Yes.
so that would be so in the literature compliance is, in fact, actually, I would tell that our compliance is not that very bad. So the literature compliance on allergen immunotherapy is that at the end of third year, only 7% is a compliance. So if you start 100 patients on immunotherapy in 2026, by 2029, only 7 of them would have completed immunotherapy. So, okay, so over 1 year, 2 year, 2.5 year, you would have had so many dropouts that at the end of third year, only 7% would have completed. This is the literature which tells, okay? But I don't think that it is that bad. Somehow it is not that bad in our practice. Maybe I would tell that the 3 year, at the end of third year compliance is still around 35% is what I would say. Most do complete 2 year, 2.5 year, but who complete 3 year and go further also are less. But that's approximately around 35% is what I would say, roughly in Indian practice. Yeah, so sometimes you can't overdo the things also. You can't keep on calling them. So it is good that you are calling for, every 1 month. We don't call that often, but we do dispense for every 3 to 4 months time if they are in and around. And we do a direct dispensing sometimes so that they don't have to come to us every time to take the medicine, though that once we do the initiation, all those things. So this has helped a little bit for our compliance of the patient and adherence, because sometimes their medicine is over and they take time to come to our place and get the medicine, and you would have lost around 1 month to 2 months in that process itself.
Yes.
And then you don't know where to start them from. Well, you would have got the third dose, the maintenance dose, but now you will have to go back to the previous vial and start. So such a small adjustment of, encouraging a video consultation, sometimes a direct dispensing, also reinforcing on pharmacotherapy. What I have felt also has is very important during the course of allergy and immunotherapy is reinforcement, readjustment of pharmacotherapy, addressing viral infections, because every viral infection will break down your that TH1 to TH2 balance. So patient would have done done very well with immunotherapy. One very bad viral inflammation, patient will start getting the symptom again. So you will have to really go back, add some more pharmacotherapy, give some symptomatic treatment, take some more time, and then do the escalation again. So all these reinforcing will need to be done again and again, and you can keep your patient, informed that if you get, such infection, please report to us. We will have to sometimes manage your medicines accordingly, and keeping them informed and not giving them unrealistic expectations. So these are also the things which will help in your practice to make them adherent. Maybe when we integrate more AI into our practice and some mode of an, where reminders through, mobile apps or their symptom score, where they themselves feel actively involved in the treatment. They know that they are also taking a part in their treatment like that. So I think those are the things which can also help in improving the compliance of our, allergen immunotherapy. So we are probably at a stage where we don't doubt whether immunotherapy is acting or immunotherapy is a real medicine or not. I think that doubt was there couple of decades ago. Now we definitely have good amount of science to tell how effective immunotherapy and the science behind immunotherapy. The only challenge that, and now we do have even the standardized allergen. Only challenge with the immunotherapy is what is your working way to keep them more adherent, more compliant. I think each one of us might have a different, way to improvise on that, and our clinic system or our hospital system that we will have to build a little more in future years on this aspect.
Yes, ma'am.
Anything more, sir, in your side or in your inputs that you have?
No, I'm just following these things only.
Oh, okay. Any more slides?
So,
Yeah.
Just to just to know that why he has not responded, why he has stopped. I did CRD also, madam, for this patient. It showed house dust mite positivity again with DERP 23 also positive, madam.
But you do
But
have other things positive too. So the DERF2, DERP1, DERP2 is also.
yes. They are also positive, madam.
Yeah.
If they are negative, then I would have thought of taking back the immunotherapy.
Yeah.
So they are also positive, hence I proceeding with the sublingual immunotherapy with the Sensimmune tablets, madam.
Okay. Yeah. So you probably would have started only with the drops that time in 2020.
Yes, madam. I did.
So what's the age of your patient now?
Now 12 years, madam.
Yeah. So now it's also a candidate for by the 12 years and above, it is legally approved also. So I think you have a good chance to start back allergen immunotherapy with the Sensimmune. But only thing is that you need to reinforce on the 3-year therapy. So all those things, you said that the parents are doctors, so sometimes it is difficult to have doctor parents, maybe. So you will have to work a little more on that. So otherwise, I think good candidate, good allergen for immunotherapy. So you have double checked with this. I think as a response wise, I'm pretty sure that this, kid will definitely respond. Yeah. So you have mentioned about all those
Yes,
things
yes.
here also. Yeah. Yes, you have justified. I think we discussed about this already. Yeah. So this we have already had a discussion in our first case itself about counseling. And you said that your plan is to start with probably the standardized allergen HTM
Yes,
for
yes.
this. Okay. Okay. I think, yeah, that sounds good. I think you have put us on the various series of cases, starting from, forward house dust mite, um, allergen sensitized patient, where still inadequate pharmacotherapy was there. And then your second case where the patient was started on immunotherapy, but didn't see a response. And then you did to see a polysensitization, and then you have slightly changed the immunotherapy prescription. And a third case where was a good responder, but lost for a follow-up, where the adherence is where we need to work on. I think, thank you very much for giving the nutshell spectrum of our allergen immunotherapy challenges that we come across. Thank you. Thank you very much, sir. Well presented.
Thank you.
Dr. Soumya, are there any questions
Yes.
from audience that we need to take?
Dr. Gayatri, can I ask you one question?
Yes, sir.
So this is related to case number 2. So in second case, when Dr. Raghuram was presenting that this particular patient was started on dust mite tablets, immunotherapy, took for 1 year, and then thereafter the test was repeated.
Correct.
And second test, the reports of dust mite were 0.
Correct.
Do not have the reports for the first test.
Yeah.
So I just wanted to ask you, and the patient has not responded also. So will there be any possibility, because of some reason, that actually this patient was never sensitized to dust mite and he was started on dust mite tablets? Because if we say that the patient was sensitized to dust mite and he has not responded, then how the skin prick test became negative,
Correct.
whereas the patient has not responded?
Yes,
So
yes.
so this could also be one of the differential along with the other differentials which you just discussed.
Correct, correct. I would agree with you, Dr. Neeraj, whether that patient was really truly sensitized to dust mite or not, and or whether the sensitization were only just barely positive, like a 3 millimeter, So where I would just tell that, and we wouldn't really choose those candidates for immunotherapy. So in fact, I wanted to ask that too. So yes, that was definitely there in my mind, whether this patient was truly sensitized to dust mite or not.
Sure. Thank you. Thank you.
Thank you.
Dr. Gayatri, if I may, I have a few questions. The main complex clinical decision making, I think, is in the patients whom we think they have polysensitization versus trying to find out if they are polyallergic. So when, say, a patient we would have had with allergic rhinitis or asthma who have sensitized to dust mites or multiple pollens. So in that case, how would you guide to decide to which allergens to include for allergen immunotherapy, just for the benefit of the audience?
Yeah. Yeah. So we will try to narrow it down as much as possible from the clinical context of it, the type of the sensitivity reaction that you have, what is more relevant in your area of practice. Some other rough guide that I also ask is whether it is itchy. A very simple question, whether it is itchy or not. So something itchy also will be causing itchiness inside the nose. So it is something very closely relates to our clinical presentation also. But having said this, it's not that easy for, especially when you have multiple pollen sensitization. See, dust mite is little more, far more easier, and you do have a little straightforward history. But with pollen, it's not that very easy to have a clear-cut allergen. So if I feel that these allergens, I narrow down the allergens, and if I feel that the dust mite is also equally important, and another, even if many polysensitized patients, they will be from 2 or 3 families, and you can still narrow it down, the allergens, 2 or 3 allergens. And if those allergens are very important, I would keep them in a separate kit, pollen as in one kit and dust mite as in another kit. The other way also is to do a nasal provocation test. You could do a nasal challenge test and find out that whether you do have a symptoms with, when you challenge the patient with allergen, you look for their symptom scoring. If you are doing acoustic rhinomanometry, you will see the difference between the pre and post. So all these things also that you can really compare it to understand between the polyallergy and polysensitization. Though nasal provocation test may not be available for everybody to do it, and we are also yet to have a good validation of the test yet. So we are also still kind of trying to validate the test. We would still be taking majority of the decision on the clinical history, your sensitization pattern, and the relevance to your area of practice. So these 3 things will majorly take a role. And if possible, do a challenge.
Thank you. I think it's the question for both Dr. Gayatri and Dr. Raghuram. How do you counsel patients for the long duration of immunotherapy in your clinical practice? I think that's one mitigating or challenge we all face in our day-to-day clinical practice.
Yeah. So, as in, Dr. Raghuram's third case, where even when patient starts feeling good, also patient will, stop taking medicines. That is also common, isn't it? It's not that patient didn't had a benefit and patient stops medication. So I explain on certain, common terms, as in, taking a immunotherapy is something like, putting your immune system in a graduation. Like, so how graduation takes, the process of a graduation would take around 3 years time. So your immune system will have to learn to start tolerating these allergens and stop recognizing them as something foreign and produce all these reactions. Now, if you just do it like a 1 year or a 1.5 year, your immune system wouldn't totally graduate and it will not have the long-term benefit. So you will still have a benefit, but it will not be for a longer time. So it will, take the complete 3 years for your immune system to learn the things and to go out as a graduate. Now, in this process of a graduation, There are some kids who will get, distinction. There are top rankers. There are also there are also candidates who fail. So similarly, in immunotherapy, there are patients who end up at the end of third year or even before that with no pharmacotherapy. So there are patients who are, requiring pharmacotherapy, immunotherapy like a 50-50%. But rarely there are people who might even fail also. So I usually use this kind of, terms when they want more explanation and more this thing that why long-term therapies are required. And one other thing that we also promise is that the effect of immunotherapy that will last longer even after I stop. So even when patient is on 1 year immunotherapy, 2 year immunotherapy, we do see that in our patient, they already are benefited, but they will not have long-term benefit if they stop at that point. So if they also want to have a long-term benefit, they will require that 3 to 5 year duration of therapy too. You know that immunologically, if I have to explain it more immunologically, that IgG, the specific IgE coming and the IgG going up will go up, IgG4 go up, even starting from the first year, and it will keep on be going up till the third year. So that achievement which you see will be complete by around 3 years time, and that's why that tenure is there for immunotherapy.
Thank you. I think one last question from my side. It is, what is one change that you think could significantly improve the uptake and the outcomes of allergen immunotherapy in our country?
Dr. Raghuram, you have any comment on that?
No, madam, please.
Now, one is, the availability of the standardized allergens, where the quality of the allergens, I think there has been a huge change. And even among the Indian allergens that we have, I have been seeing that they also have been significantly improving in last, one decade. Improvement in the quality of the allergens, integration of probably AI into, somewhere we can improvise on the adherence system. The third thing is probably if insurance covers this. So then, the people opting for this will be more.
Sure. I think this was
Just
the
my you, please, if anybody, you or anybody else have, better thoughts on that, please feel free to share it.
No. I think you have very aptly summarized the challenges we have and the things which can be worked on to improvise the patient outcomes for the allergen immunotherapy. I think these were the questions we had from the chat box and from myself. If there are no questions, I think, thank you, Raghuram sir. I think the 3 case presentations just demonstrated the variety of clinical practice you have in your vast experience and very aptly presented and worked up. And thank you, Dr. Gayatri, for moderating the session and taking time out of your busy schedule to give us oversight about approaches to different cases of patients who would benefit from allergen immunotherapy, taking through the nuances how an allergen can be selected for allergen immunotherapy. So it was an excellent case deliberation. Thank you. And I think we can conclude for the night. Thank you.
Thank you.
Good night.
Thank you. Thank you. Thank